Good morning, afternoon, or evening, and thank you for joining today's Endo-ERN webinar entitled Central Congenital Hypothyroidism, Clinical Characteristics and Cognitive Outcome in Early Detected Patients.
My name is Paul van Trotsenburg. I'm a professor of pediatric endocrinology at the Amsterdam University Medical Centers in the Netherlands. And it's with very great privilege that I may introduce speakers of this morning's, afternoon's, or evening's webinar. And Charlotte already mentioned the title of the webinar. In the Netherlands, we have a long history of neonatal screening for congenital central hypothyroidism. So the first lecture will be given by Professor Anita Boele, head of our National Neonatal Congenital Hypo Screening Program. And the second and third lectures will be given by Dr. Nita Swavling-Sunawala, my colleague pediatric endocrinologist, who will speak about clinical characteristics of detected patients, followed by Dr. Jolanda Naafs, who will speak about the long-term outcome of these early detected patients. After the lecture, Charlotte already mentioned that there will be room for questions, and well, all that rests for me is to wish you a very informative 1 hour. So Anita, the floor is yours.
Yeah, thank you, Paul. I don't see any slides so far. Is that right?
I will show them, Anita.
Yeah, okay. Next slide, please. It's about neonatal screening as a start, and neonatal screening is a screening that's performed in newborns within a week after birth in order to detect a variety of inborn errors. In the Netherlands, it's a national organized program coordinated by the National Institute of Health. What we do in the Netherlands, blood is taken within 4 to 7 days after birth by heel prick. The blood is spotted on a filter paper card and sent by regular mail to one of the 5 screening laboratories in the Netherlands. These laboratories are located throughout the country, and they each have a couple of provinces where they measure the heel prick cards. In the Netherlands, we have approximately 170,000 babies a year, and we screen at the moment for 23 diseases per day in the heel prick. The program is under currently under will be extended. So a number of diseases will be added to the program. And at the moment we have endocrine and metabolic inborn errors, sickle cell disease, and cystic fibrosis. Next slide, please. One of the inborn errors we screen for is congenital hypothyroidism. This screening is started in 1982 in the Netherlands. The incidence of congenital hypothyroidism is 1 out of 3,200, and that means that we detect 50 to 60 patients per year. Next slide, please. Well, congenital hypothyroidism is a shortage of thyroid hormone measured in the blood, and this is due to a thyroid gland that is absent or non-functioning. We have 2 types of congenital hypothyroidism, the thyroidal type CHT, which is the result of a thyroid gland that is not present or ectopic or has an organization defect, resulting in impaired production of T4. But we have also central hypothyroidism, and this is due to a suboptimal stimulation of a normal thyroid gland by TSH. So, congenital hypothyroidism results in growth and mental retardation and in physical abnormalities. It's difficult to detect shortly after birth. It's easy to treat, and it's therefore an excellent disease to be taken up in the screening program. And the therapy of congenital hypothyroidism is lifetime use of thyroid hormone. Next slide, please. Well, as I mentioned, we have 2 types of congenital hypothyroidism: the thyroidal type, and this is occurs quite often, 1 out of 2,500, characterized by very low levels of T4 in the blood and an increased concentration of TSH. And the central form of congenital hypothyroidism is a rare disease with an incidence of 1 out of 16,000. It's also characterized by low levels of T4, although less severe decrease than in thyroidal congenital hypothyroidism. But in contrast to the thyroidal form, the TSH is not increased, sometimes slightly decreased, but in most cases just normal. Most neonatal screening programs for congenital hypothyroidism are based on the measurement of TSH, which means that they are able to detect the thyroidal form of congenital hypothyroidism, and that the CH, the central form, is not detectable. In the Netherlands, next slide please, we have a different program, and in the Netherlands the primary marker is T4. And it's a complicated screening algorithm. I will let you through this. What we do is we measure T4 in all the Hilp records that we got in the lab, and we express the T4 as an average value of the animal per liter blood, and we also calculate the standard deviations of the daily mean. And in case if the standard deviation is equal or lower than -0.8, in that case we also measure a serum of a TSH in the blood spot. That means that in 20% of the lowest T4 values we measure TSH. What we also do is we measure in 5% of the lowest values, which is equal to a standard deviation of -1.6 of the daily mean. We measure the thyroid hormone binding globulin, TBG, and we do that in order to be able to detect TBG deficiency, which is a cause for low T4 values, and we also do this in order to calculate T4 TBG ratio, which serves as an indirect measure of free T4. And so we have a complicated algorithm. We do 3 tests, T4 in all the blood spots, TSH in 20% of the lowest values, and TBG in the 5% of the lowest values. Next slide, please. Well, we consider T4 lower than -3 SD as low, which is a reason for referral to the pediatrician. We also consider TSH higher than 22 as high. It's also a reason for referral to the pediatrician. And a T4 TBG ratio smaller than 17.5 is also when we measure that twice in a second blood spot. This is also a reason for referral. And well, a low T4 combined with a high TSH is suspect for primary hypothyroidism, and a low T4 and a low T4 TBG ratio twice measured is suspected for central congenital hypothyroidism, and also a reason for referral. So these 2 outcomes do we have in the Dutch algorithm, and in this case we can distinguish between the primary form, the thyroidal form, and the central form. May I have the next slide, please? Well, we have this program since 1981, and well, that is more than well, 30 years, if I'm correct, 40 years maybe. And in the meantime, we have had some adaptations and observations. In 1983, it became clear that premature babies, T4 is not the best marker for premature babies, because they have often low T4 values because of prematurity or illness. And in that case, we added TSH for these newborns. So in case a gestational age lower than 36 weeks, TSH is the primary screening marker. That's the premature rule, and it's added in 1983. In 1995, we added the TBG to the screening algorithm and used the T4 TBG ratio I already discussed. In 2012, we adapted these TBG rule, and we decided to to wait for the TBG in case of a low T4 measurement and refer the baby when the TBG concentrations are known. In that case, we won't refer babies with a TBG concentration lower than 40 nanomole per liter, which is a TBG deficiency and the case for a low T4 levels. In 2015, we noticed within the screening community in the Netherlands that we had an increasing number of false positive referrals. This was first observed by the pediatricians who got a lot of children in their clinical practice with referred out of the screening, which were completely normal. And in that case, a working group was established to evaluate the screening on congenital hypothyroidism. May I have the next slide, please? Well, one of what we did at that time is a PhD student of the Amsterdam University Medical Center did an evaluation in collaboration with this working group of the neonatal screening in the period of 2007 to 2017. And what we found was that we had more than 3,000 referrals for CH. 612 CH cases were detected. The most were CHT, and we had 86 central hypothyroidism cases. And what you can see in this slide is that a huge percentage of the cases were false positive, 80% of the cases, which is substantial and also well, not the desired situation, I have to say. And what we also noticed was that a substantial part, 45%, was due to the T4-TBG ratio. And based on this observation, we had a closer look at the TBG assay, and we made some adaptations in order to get a more stable level of the measurements, which reduced the number of referrals markedly. May I have the next slide? What we also noticed was that it might be good to have information about the reference values of, for example, TSH and TBG in healthy newborns, because in our algorithm we only measure TSH in the 20% lowest T4 values and TBG in the lowest 5% T4 values. We didn't have the information what are normal TBG values. And it's Kevin Strook in our lab did this study, and he established reference values for TBG, which are the most interesting, I think. And these TBG reference values are quite high, and between 160 and 271 nanomole per liter blood. And can I have the next slide, please? And when we have a closer look at the cohort I mentioned before, with all the referrals we had in the period of 2007 till 2017, we had a substantial number of false positive referrals with a TBG value below reference interval. And in that case, resulting in low T4 values, which are due to the low TBG. And partial TBG deficiency is also described, and well, it's very well possible that a part of the cases we refer have a partial TBG deficiency and therefore low T4 levels. And in that case, we checked this observation in the more recent cases we found in the congenital hypothyroidism, the most recent referred cases. And it was quite clear that we were able to adapt the algorithm to reduce the number of false positives. And we now have put the TBG lower limit at 105 instead of 40, which means that we, when a child has a TBG lower than 105, it's or partial or complete TBG deficiency. And in that case, it will not longer be referred to the pediatrician. Can I have the next slide, please? And next slide. So that means that in 2021 we adapted the TBG rule and set the lower limit at 105 instead of 40, and we have to see if this results in a better outcome with regard to the referrals we have for the central congenital hypothyroidism. Can I have the next slide? So in conclusion, we have a congenital hypothyroidism screening since 1981. We have a 3-steps algorithm. We measure T4 in all the cards, TSH in the 20% lowest and TBG in the 5% lowest. We detect both the thyroidal form and the central form of congenital hypothyroidism. We evaluate the program and which revealed that TBG is a main factor for the huge amount of false positive referrals we had. And it also illustrates, our studies also illustrates that we have a continuing improvement of the program in order to reduce the false positive referrals. Can I have the next slide, please? I would like to thank for this work Kevin Stroek, a PhD student in our hospital, Paul van Trotsenburg, Nita Schwaveling, and Marja van Veen and Ingrid Metgold, especially for the studies we did on the reference intervals. I would like to thank you for your attention.
So as Anita and Paul told you, we have a long history of screening for central congenital hypothyroidism in the Netherlands, and especially since 1995, after the addition of TBG to our screening program, it has become a very efficient way of detecting central CH. Recently we set out to study what actually is the yield of our neonatal screening program. We studied a 20-year cohort starting in 95 up to 2015, and we asked ourselves, what are the diagnoses, what are the clinical characteristics of these patients? And we were especially interested in their cognitive outcome and quality of life results in the long term. And Jolanda Naafs will show you the cognitive and quality of life results, and I will show you the clinical characteristics. Next slide, please. So we have published these results in December last year. Next slide, please. And some numbers to start off with. So it's a 20-year cohort, and the Netherlands, of course, is not a very large country. We have about 1,700 people and a birth rate of around 170,000 a year. So in that 20-year period, there were just above 380,000 live births, of whom 7,700 children had died before the newborn screening could be performed. We have a very high rate of neonatal screening in the Netherlands. 99.7% of children participate in the screening. And in this 20-year cohort, we had 154 cases of central CH. 6 of these were transient, mainly due to maternal graves causing transient central CH. So we were left with 148 cases of permanent central CH, and that gives an incidence of 1 in 25,000 live births. Next slide, please. So we started off with 154 children. We used the TNO database, which registers all abnormal screening results, to try and locate all these children. We traced them, we contacted their treating pediatricians or physicians and asked for permission to review all medical details. And we also asked children to visit our center to have cognitive and quality of life testing done. So in this group of 154 children, there were 94 cases of MPHD and 60 cases of isolated central CH. So as you see, 2/3 consist of MPHD, multiple pituitary hormone deficiency. Next slide. Both these groups can be divided into syndromic and non-syndromic forms. So we have syndromic multiple pituitary hormone deficiencies. So that's MPHD associated with other within another syndrome. And we also had 4 cases of isolated central CH within a syndrome. And on the next slide, you see the syndromes we found. There were various syndromes within MPHD, not surprisingly, many cases of septo-optic dysplasia, 2 cases of holoprosencephaly. There was also a case of congenital disorder of glycosylation, and we also found 2 cases of CDG in the isolated central CH group. As you see, quite a few of these children had died within the first months of life. And when we were tracing these 154 children, we had 15 cases of children who had died. So we got permission to review all their medical charts, and it turned out that all these children, except for one, had other congenital malformations, syndromes, birth asphyxia, neonatal infections. And there was only 1 case of a non-syndromic MPHD boy, 9 months old, who was treated with various hormones, also hydrocortisone, but he became unwell overnight, developed high fever, and he was the only case of which we could say he really died because of an acute adrenal insufficiency. So we concluded that the mortality is quite high, but associated with other disorders, and only in 1 case there was actually death due to the pituitary hormone deficiency itself. Next slide, please. So when we go to the non-syndromic forms, you see those are the majority of cases, and especially the non-syndromic MPHD is most prevalent. So we had 80 of those cases, and we had 56 isolated central CH cases. We asked all these children whether they would participate in our follow-up study, mainly aimed at cognition, and we were able to include, next slide, 57 MPHD patients and 35 of the isolated cases. And I will show you their clinical characteristics. Next slide, please. So we started off with 57 MPHD and 35 isolated central CH, and at follow-up, they were 10 years old in the MPHD group on average and 13 years in the central CH. And as you see, there were many more males, not only in the isolated central CH group, which is not surprising since most cases are associated with X-linked genes, but also in the MPHD group, there were more males. You see some perinatal data, and the breech position is one which is quite obvious in the MPHD group, and that has also been described before. Next slide. As we were reviewing the medical detail, we were surprised to see that 61 children, 50 MPHD and 11 isolated cases, were hospitalized before the newborn screening result was in. And the reasons for hospitalization were hypoglycemia, feeding problems, prolonged jaundice, sepsis-like illness. And in the MPHD group, there were quite a lot of boys with micropenis. But surprisingly enough, on the next slide, most of these children were discharged without a diagnosis of pituitary insufficiency. Only in 3 cases the diagnosis was made before notification of the abnormal neonatal blood screening result. And in a large number, the children had actually been discharged before the diagnosis was made, and then were recalled once the screening results turned out to be abnormal. So this emphasizes that the clinical diagnosis is not often easy, and we probably healthcare workers need to be aware of this very rare endocrine disorder. Next slide, please. So of the 57 MPHD cases, they had a diagnosis on average at day 17, and they started their treatment. And they obviously all had central hypothyroidism because they were all from the neonatal screening. But nearly all children had growth hormone deficiency, a very large number had HTH deficiency. And at follow-up, so at the average age of 10, we could assess the gonadotropin deficiency in 27 patients, and 20 of those had actual deficiency. Next slide. Almost all children had an MRI performed, 45 cases, and in 84 cases there was what is known as pituitary stalk interruption syndrome, PSIS. 2 children had a septo-optic dysplasia, and 4 children had no pituitary abnormality on their MRI scan. And on the next slide, you see a picture of PSIS. PSIS consists of the classic triad of an interrupted or absent pituitary stalk, an ectopic posterior pituitary, and anterior pituitary hypoplasia or aplasia. The combination can be very variable, but it usually consists at least of either the ectopic posterior pituitary or the absent or interrupted pituitary stalk. And on this picture, you can see at panel A the bright white spot of the ectopic posterior pituitary at the base of the hypothalamus, which is a very characteristic bright white spot on the T1 weighted MRI. Next slide, please. When we look at the free T4 levels of our PSIS patients, at diagnosis, the average free T4 concentration was 8.7 picomoles per liter in an assay with an adult reference range of 10 to 22. At diagnosis, so at around 2 weeks, we know the reference range is quite a bit higher than the adult reference range. We recently performed studies on that, and the lower limit of the neonatal reference range at 2 years is about 3 points higher than the adult reference range. So in that respect, 8.7 is really low. And in this figure, we have actually plotted all the individual values of the PSIS patients on the right side. So those are the free T4 values of our individual PSIS patients compared to the lower limit of the reference interval. So it's in percentage of the lower limit of the reference interval. And in the other boxes are all the free T4 levels of isolated central CH cases, which have been mentioned in the literature, and also including our own patients we found in this study. And as you see, the TSH beta patients have the lowest free T4 levels, but second are the PSIS, so they have quite low free T4 levels compared to the other mainly X-linked forms of central CH. Next slide. So we had 57 MPHD cases, and we had 35 isolated central CH cases. These children had diagnosis on average at 21 days and started treatment. And they had genetic testing performed. And most cases had IGSF1 mutation. There were 5 cases of IRS4, 5 of TBL1X, and single cases of TSH beta and TRHR. In 3 cases, those were 2 boys and 1 girl, there was no genetic defect. And in 3 cases, genetic testing was not performed, 2 girls and 1 boy. Next slide. So the average 3T4 level of these central CH patients was a bit higher than our PSIS. If you recall, the PSIS group had an average 3T4 of 8.7, and in the isolated CH patients it was 10.4. And this again is the same picture. And as you see, we had mainly IGSF-1 patients, and that's also what we found in the literature. The actual 3T4 levels of many IGSF-1 patients are plotted in this figure. Next picture, please. So in our cohort, quite a few patients, 60 patients, had a TRH test. TRH test is not readily performed anymore because TRH is not easily available and it's quite a laborious test. But we were able to retrieve the results of 60 patients in our cohorts. And what you see in green, the MPHD patients, and in orange, the isolated central CH patients, is that practically all MPHD patients had an exaggerated TSH response. So they have an exaggerated high TSH elevation with also a delay in decline. So this delayed rise of TSH is classified as a type 3 response in the TRH test, and we feel it is very indicative of MPHD. So although there is a lot of controversy about the TRH test, in case of type 3 response, there is a very high suggestion of MPHD. Next slide. So when we are faced with a child with a newborn screening result indicating central CH, we do not perform TRH test anymore, although we did do that in the past. What we now do is first, of course, you have to confirm the low T4 in the blood spot by a venous measurement, 3T4 and TSH, and you have to compare that to age-corrected reference intervals. Neonatal reference intervals are higher than the adult reference interval. You have to rule out other causes of low 3T4 like prematurity, non-thyroidal illness, medication, certain anti-epileptic drugs, and maternal Graves' disease. And if there then is a true suspicion on congenital central hypothyroidism, we admit children to hospital and monitor for hypoglycemia because you do not want to miss potentially brain-damaging hypoglycemia. And then we perform a low-dose ACTH test very early on to test for central adrenal insufficiency. And on the next slide, you see that the low-dose ACTH test result is the most important deciding point. If the result is abnormal, then the diagnosis seems MPHD, because then you have central hypothyroidism and ACTH deficiency. You first start hydrocortisone treatment, followed by thyroxine treatment, and we perform an MRI, and in those cases, PSIS is most likely finding. And of course, you need to test for other pituitary functions. In case of a normal low-dose ACTH test, then probably the case is an isolated central CH. We start thyroxine and we rapidly perform genetic testing for the 5 genes known to be associated with isolated central CH. If the genetic case cause is found, then of course you have a confirmed case and you can counsel family members. But if you do not have a genetic cause in these known genes, then it could be an isolated central CH case without known genetic cause, but you can also not completely exclude MPHD, especially because we know that other pituitary insufficiencies can develop over time, like evolving STH deficiency. So in those cases, we consider children to possibly have MPHD, and we perform MRI and also test for other pituitary functions and regularly monitor the ACTH production. Next slide. So from our study of 20 years of newborn screening for central CH in the Netherlands, we learned that 2/3 of the patients have MPHD, 1/3 have isolated central CH, and that most non-syndromic MPHD cases consist of PSIS. So the majority of our cohorts were PSIS patients, and most isolated central CH patients could be genetically confirmed, and half of these patients had IGSFN1 mutations, followed by RS4 and TBLN1X. The majority of the neonates had been hospitalized in the first week of life, but this rarely led to a clinical diagnosis. So that emphasizes that it's a difficult diagnosis, and in our cases, newborn screening really helped in identifying these cases early and starting treatments early. But of course, the value of the newborn screening for central CH especially lies in improving the outcome in the long term, and that is what Yolanda will show you. She will show you at least the outcome of our early treated cohorts. So on my last slide, I would like to thank my co-workers at the Department of Pediatric Endocrinology and Adult Endocrinology at Amsterdam UMC, the Endocrine Laboratory, TNO Leiden, of course, all the patients and parents that participated, and this study and the following study to be presented were sponsored by Pfizer. So then Yolanda will show you the results of the cognitive.
I would like to discuss the long-term outcomes of patients with central congenital hypothyroidism, and I will discuss two studies that were actually the main part of my PhD project. And of course, as Dr. Zwaveling told you, these are all data on early detected patients, since we detect central CH early in the Netherlands. So before we started these studies, this was actually the incentive to start looking for more information, because we knew there was only little data available on the prognosis of patients with central CH. So this study that I show you has been performed over 10 years ago, and authors were able to collect well, over 40 patients with central CH, which is admirable, but they were only able to assess their medical charts and see whether developmental delay had been mentioned in the chart. So we concluded there was still a knowledge gap, showing us that we do not know that well what the outcome of a patient with central CH is. So we set up a study in which we aim to assess both cognitive outcome and motor skills, as well as quality of life of these patients. And for cognitive assessments, we used intelligence tests. To assess the motor skills, we used questionnaires, and to assess quality of life, we used questionnaires as well. We were able to perform this study, as Dr. Zwaveling said, and Dr. Boele also said it, with help from TNO, which is a large organization in the Netherlands that has been storing data on CH screening since 1981. And we invited a group from a 20-year period to make sure we had enough patients. So the first article has been published in the Journal of Clinical Endocrinology and Metabolism. Well, it was accepted last year, but it has been published this year, and it focuses on the cognitive outcome. So we performed a nationwide recruitment, inviting all patients through their own pediatrician or physician. And we actually had only one important exclusion criterion, which was that if there was a severe syndrome that impaired communication with the patient, that the patient could not participate. And of course, this is because the intelligence test is a very interactive test with an observer, and you need to be able to communicate. Otherwise, there is no reliable result. And as a control group, we asked siblings to participate as well and perform an intelligence test as well. And they had to be 3 years of age at least, because this is the youngest age to reliably perform this intelligence assessment. And this also the patients had to be at least 3 years old. So most importantly, we used Wechsler intelligence tests, which are pretty commonly used tests in psychology, and we used age-specific tests, so either a preschool test, a children's test, or an adult's test. These tests give us the full scale IQ, but also some sub-scores to create a better overview of if the patient has a lower IQ, what is actually causing it. So we also looked into performal and verbal IQ and processing speed. I will come back to that later. So just to give you a short example, this is what a test could look like. This is from the adult Wechsler test. And here the question would be, which 3 pieces would you need to complete the puzzle as you see above? So the answer would be the first, the second, and the 6th piece. And after this, the difficulty of the test increases rapidly. So just to give you an idea of what our patients went through. And afterwards, of course, we had to do statistical analysis, and having a sibling control group is actually ideal because siblings come from the same family, so many confounders are corrected for. But when you analyze these data, you have to take into account that patients and sibling come from the same family again, and you have to make sure to correct for that. While some families do not have a sibling, and we also had 2 types of disease, which we had to correct for. So to solve all these problems, we use linear mixed models. And this means that we will always show you the comparison across 3 groups. So MPHD patients, isolated central CH patients, and siblings. So first, we were able to include almost 90 patients and 52 siblings. Among patients, we see a large male predominance, which is not unexpected, and was also shown by Dr. Zwaveling earlier. So the groups were pretty well comparable in terms of age and gestational age. And if we look at maternal and paternal highest level of education, these are pretty well comparable to the general population as well. Just really quickly looking into the data of these separate patient groups, we see that MPHD patients have a lower 3T4 level before they started treatment, and they more often have moderate CH, while the severity of CH in isolated central CH patients is more often mild. We assessed the 3T4 concentrations in all patients before they did their IQ test. And as you see, these were almost all within the reference interval. So I think this is the most important figure showing all outcomes. So if we start on the right, you see that the siblings are represented over there, and the box represents the mean with 1 standard deviation above and below it. And in the gray area, you see the general population with a mean of 100. And you see that siblings are really well comparable to the general population. And if you move 1 box to the left, you see that isolated central CH patients are also really well comparable to siblings. So there's no difference in full-scale IQ between isolated central CH patients and siblings. So if you move again one box to the left, you see the multiple pituitary hormone deficiency patients. And you see that they score significantly lower than the other two groups. So they have a mean which is approximately 8 points lower. But if you check all the data, still a large part of the results is within the normal range. So that's reassuring. But it has to be said that also a smaller part is below 70. So these are the same outcomes, but just in numbers. So you see that the mean full-scale IQ does not differ between isolated central CH patients and siblings, but it does differ between MPHD patients and the other two groups. And if we look at other subscales of intelligence, for example, processing speed, we see other differences. So processing speed is the speed at which you complete a relatively simple task. So anyone should be able to do it correctly without mistakes, but what it requires is speed and concentration. And we see that both groups score below average, and both groups scored 10 points below average. So this is a really interesting finding because in the full-scale IQ, we only see that MPHD patients are affected, and this might be explained by their more severe hospitalization in the neonatal period. So the hypoglycemia that they went through and the additional pituitary hormone deficiencies that might or might not have been detected early. But for processing speed, we see a different image. So we see both groups are affected similarly. So we suspect that this has to do with the period of hypothyroidism before treatment. And this might be either a result of the postnatal period with hypothyroidism or the prenatal period. So we also assessed motor skills by using a questionnaire for parents. And this was a similar result in both patient groups. So 1/3 in each group experienced difficulties, and approximately 1/3 in each group also had physical therapy for their delayed motor development. So both are significantly different from siblings in whom this was much less often the case. So to sum up this article, intelligence quotient in patients with isolated central CH that have been early detected and thus treated early is similar to siblings. However, IQ in patients with early treatment of their multiple pituitary hormone deficiency is lower than siblings, approximately 8 points. But it's reassuring to see that most of these patients still have an IQ within the normal range. And strikingly, we see a processing speed that is affected in both groups of early detected patients. And when it comes to motor difficulties, we see the same, that both groups are affected more often than the general population. So we asked the same patient group to also fill in questionnaires on health-related quality of life. This group is almost the same, just some patients were reluctant to take the intelligence test, but took the questionnaire on quality of life anyway. So the difference is just one patient. So we had a similar study design. And this time we asked the patients and their parents to fill in a generic questionnaire on quality of life, so the PET score, and an extra subset of the PET score, which focuses on fatigue. If the patient was younger than 8 years of age, it's recommended to only complete a parent report. For patients under 90 years of age, we let them complete a self and a parent report. And patients or participants above 90 above 18 years of age could complete self-report only. And these questionnaires do not only report a total score, but also sub-skill scores on physical, emotional, and social functioning, and role functioning. And role functioning refers to the role that you take up in school, work, or study. So to correct for testing these much assumptions, we had a p-value lower than 0.001. So if we look at the self-reports, we see no significant difference across the three groups. However, if we look at the parent-reported scores, we do see significant differences. And these all come down to differences between MPHD patients, parents, and siblings. So the parents are more worried, and this shows in the total score, but also in the scores for physical functioning and social functioning. And we see actually pretty similar result in the questionnaire on fatigue. So the patients seem to be pretty satisfied with their level of fatigue. But parents tend to worry much more, and they give their child with MPHD a lower score for total and general fatigue. Yeah, to sum it up real quickly, this would be the conclusion. And why would this be? Well, there are several explanations possible. Most importantly, we think parents feel the responsibility to give the medication in time, especially if there's ACTH deficiency. This will lead to more worry from the parent than from the child, who is more looking at life from a day-to-day basis. And in addition, we also know that the parent report is not 100% similar to the child's report. So these differences between patients and parents have also been observed in quality of life research, for example, in patients with epilepsy. So after showing you all these data, there's still, of course, some questions remaining. And the most important for now, I think, would be what are the differences between early and late detected patients with central CH? So I've now shown you everything that we know on early detected and early treated patients. But if we knew how late detected patients, so anywhere else but the Netherlands, I guess, how these patients would perform on such an intelligence test, we could also answer the question whether neonatal screening actually improves long-term outcomes in central CH. We suspect it does, but it's just an hypothesis for now. And if we are to study this any further, it would also be good to know why do MPHD patients differ so much from isolated central CH patients? Because we have some hypotheses that it's mainly in the pituitary hormone deficiencies and the worries about taking hydrocortisone in time or increasing the dosage if necessary, but we're not sure. So to sum it up, once again, this is what we found in patients with early treated central CH. The full skill IQ of patients with isolated central CH is similar to siblings. The full skill IQ of patients with MPHD is below average and below the sibling scores, so 8 points lower on an average score of 100. And processing speed scores are lower in both groups. Motor difficulties are also seen more prevalently in both groups, but health-related quality of life, according to the patients, is similar to their siblings. And with that, I would like to conclude and, of course, thank all the collaborators, both from the AMC as well as from TNO, and, of course, all the patients who were willing to participate in these tests for us.
Yolanda, can I ask you a question? because you said that you ended with that that it's a hypothesis that early detection and early treatment improves the outcome of the children we spoke about. What is necessary to have more evidence, of even more evidence than we have now, that early detection and early treatment is beneficial?
Yeah, to scientifically prove that it's beneficial, because I'm already pretty much convinced, but I think we would need at least a small group of late treated patients. So for example, starting after day 60 of life, day 90 of life, in whom we could perform an intelligence assessment. That would just be it. I think we would just need 30 or 40 patients, and that would be sufficient to compare it to our own group of patients. And
Okay,
of course, then there you would need a difference to say this is the better outcome.
Yeah, and then a question to you, but also to Nitash. And what kind of patients do you refer to? Because in the Netherlands, we find these patients because of their abnormal neonatal screening result. But if in a region or country the screening doesn't pick up central hypo, how do these patients present? Maybe Nitash, you can comment, because I think there are various periods in life which are typically the periods that these patients can present.
As well, the majority of our patients were, of course, MPHD patients based on PSIS, so pituitary stalk interruption syndrome. So that would be a good group to compare our results with. And patients with PSIS may have central hypothyroidism, but often without neonatal screening are detected because of poor growth, so they will be diagnosed when they are analyzed for short stature. And another phase in life is, of course, when puberty doesn't start. But I think it would be possible to create a group of non-syndromic PSIS, because those patients would really be very comparable to our patients clinically, and then we could have cognitive testing done. For the isolated central CH patients, it will be more difficult because the diagnosis is really based on thyroid function testing, and the clinical characteristics may not always be very apparent.
Yeah, I agree.
I see some questions in the question box. Can you also see them, Paul?
Yes, but I don't have, okay, I have the question here and I can read it aloud. And the first question is from Cécile Bachet. Hello, thank you for this presentation and nice work. Do you have some intelligence data of all patients with IGSF1 mutations that have not been diagnosed through neonatal screening? Nitash, can you comment on it, or Jolanda? Because Jolanda, you included some of those patients with central hypo due to IGSF1 mutation in your systematic review.
I just missed the middle part of the question, so could you repeat it?
Yeah. The question is, do you have some intelligence data of older patients with IGSF1 mutations that have not been diagnosed through neonatal screening? And I remember Jastra did a study on that.
Yeah, he did. However, we were not able to include those data because there has been a study on IGSF1 and cognitive outcome, but this study focuses, well, at least what they report is data on concentration and memory tasks. So there is not data available on numbers of IQ. But in the study of Shujiao, they found, if I remember correctly, no difference to healthy control, or only slight differences with healthy controls. But it has to be said that this is not intelligence data. These are just subtests of an intelligence test. And we also performed a systematic review. But if we want IQ scores only, there is no data on IGSF-1 patients that were treated later.
Yeah, correct. Okay, there's a second question. This colleague asked, thank you for presenting this very important data, very nice presentations. What about false negatives with your approach to screening? So the question is, what about the false negatives? Maybe Anita, can you comment on this, about the number of false negatives?
Yeah, the number of false negatives. Yeah, that's slightly difficult because we don't have a real national registry for all these cases, and it should be reported if a child has been missed, but it's not always the case. But I think well, maybe 3-4 children per year, Paul.
Yeah, that's it. Yeah, that's what we found. We conducted a study in children who were diagnosed with the presumed diagnosis isolated growth hormone deficiency, and those children were typically between 3 to 6 years of age when they presented. And we found that in this 10-year national cohort that was really complete, that approximately, it was a cohort of about 250 children, and about 25 to 30 of these children had a low free T4 at the moment of diagnosis growth hormone deficiency, or their free T4 level really declined after the start of growth hormone and didn't return to normal. So based on these criteria, they were diagnosed with central hypo, and that's indeed 3 to 4 children per year. And we look back at their neonatal screening results, and they were lower than normal, but we only could analyze a small group of these children with respect to their neonatal screening data, because they were not recorded then in that times.
Exactly, and
so
the thing it's most of the times due to the fact that the T4 is not low enough to get a TSH measurement. So because the TSH, it's very sensitive, and when we miss children, that's because of that the T4 is not low enough to get a TSH and sometimes a TBG. So it's due to the T4. But well, I think the biggest problem of our screening is the amount of false positive results, and not the amount of false negative.
And still, despite that we measure thyroxine binding globulin, we still have false positives.
And of course, we also miss all the prematurely born children, because they continue to have only a TSH screening.
Yeah, exactly. So that's also, and I think that's an adaptation we should think of, is to make a more sophisticated premature rule, for example, and to get all the premature babies a second heel prick at the presumed time of birth, so at week 40, for example, to see, and then you can measure T4 as we always do. And
sure. Okay, thank you. At this moment, there are no other questions.
Yeah, that's correct. So it seems that your presentations were very clear to everybody. Thank you very much for that. So is there anything else, Yolanda, Nitash, Anita, or Paul, you would like to cover before we wrap up?
Well, I think maybe the last words are on the words by Yolanda and Nitash about at least an attempt to conduct a nationwide, not a nationwide, but a European study in centers with late detected patients with central CH as part of combined pituitary hormone deficiency, and preferentially with PSIS, to conduct a study to their outcome. and to compare it with our results. And we will be writing a proposal on that, and well, we'll get back to you. And I think Endo-ERN is a nice organization to reach out to other European countries and to start up such a study. So I think these are my final words for now.
Yeah, totally agree.
Yeah.
Okay.
Okay. Thank you.
Well,
thank you for your attention, and maybe the last words to Charlotte.
yes, well, I just wanted to add thank you, the speakers, but also all attendees for your, well, the speakers for your valuable and excellent talks, and the attendees for your attention and your focus. And well, hope to see you in one of our next Endo-ERN webinars. And if you would like to review or let your colleagues view this webinar, please note that the webinar will be available online within 1 week about. So thank you very much, and have a nice day, afternoon, evening, morning, whatever you are, in which time frame you are.
Thank you, Charlotte, for your help.
Okay. Thank you. Bye.
Thank you.